Thank you. Welcome back. And we have with us Senator Lyons, the sponsor of 197, I believe. And are you the reporter of this bill as well? Yeah. Might have to crypt your bill report. So tell us about the bill. We've been taking testimony for the last.
I understand that. And first, thank you for having me in, Senator Ginny Lyons, for the record. And I really appreciate your taking up the bill and having looked through it so quickly. And thank you for doing that. So we started this bill together last year. We understand that when putting in the primary care advisory committee into Act 68, that is really important and fundamentally, I think, has given us the next direction for healthcare reform, which is to improve workforce and access to primary care. Also, reducing administrative burden through primary care. And I started thinking about what could we do next last June when we left. And I know that others have been thinking about this as well. So there's a lot of ideas that are reflective of folks in the House as well as in the Senate, and the work that the advisory committee and the Vermont Medical Society have done, but all reflected in the bill. So you're hearing all that testimony, and I think the benefit of all of that is that we continue to work together proactively. I'd say there are areas of the bill that are very important to us. I'm not going to go to specific paragraphs or sentences, but alignment of payment is critical, and that alignment of what each of our payers provides to primary care, which will automatically reduce administrative burden, and to sorting out which codes, how the codes sort out, I guess is the way of saying it. So that's one area that's important. Moving toward utilizing some type of index to determine payment. So the Medicare Economic Index, looking at risk-based payments, depending on what kind of service is being provided, but also what kind of practice or clinic or individual caregiver is involved. That's that whole area, which is so important, relying on resource-based value scores, just looking at the whole payment piece and having it be uniform and aligned. The word that we talk about in our committee all the time, and you probably do too, is alignment. And this is an opportunity, I think, to do that. The other piece I think that's important is opening up payer-provider contracts, and including increasing transparency of payment, so that and requirements within payer contracts is so critical to have our clinics and our providers work independently, but also without undue pressure. And then I think the coordination between the blueprint and independent practices, building a payment system that is inclusive of all primary care is very important. Our blueprint is so outstanding. It really is, and has become nationally known, as you know, we all know this, but being more inclusive of the community-based services and the type of care that can be given by our social workers or our nutritionists or others, physical therapists, whomever, that will inform and improve access to primary care for patients. Those are the kinds of things that I see within the bill. So, but it's really about payment, and how do we pay for all of that, and how do we pay for blueprint practices, independent practices, and make it equitable across the state. We have such a good foundation whether it's through Blueprint or F2HCs or others, in taking some of these steps forward. And I know that you've been through it probably with Jen already. And we also just, the one fact that we can't forget is the savings that we all know that, right? The savings we got by investing $1 in primary care.
How much is the savings?
Well, some people say $13, but the new number is $18. We'll have to debate which one is
I know.
accurate. But so, right, so the return on investment to reduce risk and high cost from care later on is implicit in what we're doing. I don't know that you want me to spend much more time on this, because I think you're all probably diving into the words at this point and trying to sort it out. I do thank you for doing that. I know that a big chunk of our healthcare dollars all go to the hospitals, and we're trying to understand how we can balance that investment with primary care investments. And in a way, keep people from the hospital, but hospitals don't like that, but I think they do. I think they know that we don't want to have people going to EDs when they don't need to. So if we have more primary care practices across the state as we go through the state action plan and do all of this work that's in front of you, we can avoid some of the chronic issues and the people going into EDs on a regular basis.
Questions for Senator Lyons? I have a couple, but if anyone has any, I will defer. Go ahead.
I've heard concerns up my way about hurting the small hospitals.
Yeah.
Can you tell me how that would?
This bill
Yeah.
hurting the small hospitals? I don't know if they have,
Probably 190.
that's 190.
Yeah.
Different bill.
This is only the.
197, I'm sorry.
Yeah, 190. Good
Still
question,
understand.
we can talk later.
No. I'm looking at 197, but my
It's okay,
questions are.
no, sorry.
Yeah, I think that's 190, which we haven't gotten to yet.
Oh darn.
So how do you imagine, I mean, one of the problems that we have right now with the existing blueprint, as you well know, is that the blueprint supports everyone at a patient-centered medical home, and yet only certain payers invest in the blueprint. How do you envision that we would be able to do this when we are constrained by Medicare and self-funded? How do we get buy-in from, let's start with the self-funded. How would you imagine that we would get buy-in from the self-funded?
Well, I think, one of the things that we can do is to invest, have a payment model consistent for, just take our QHPs, the way it is in 190, but just looking at QHPs and having some consistent payment based on risk, the risk associated with the patient pool that's in a practice or the type of clinical practice that exists, and having that payment in place. So, and then making the payment sufficient that people access the care. Then we also know that there are a certain number of visits to our primary care that perhaps they're not free, but they're accessible without out of pocket or copay. And so once you have established that you can have 2 or 3 of those visits a year, then that's very attractive and people will start using it. So how do we take care of self-insured? I think we make it attractive to have this type of model in place. It provides its own incentive. we just can't control ESI, know that. There are other things that we potentially could do, I think. That's just one thought.
I had a question. I'm curious. And by the way, I like the language. I'll just preface by saying I really like the language. You've added language to existing statute that currently the blueprint is based on NCQA, patient-centered medical home.
Yep.
And you've now added or another quality standard identified by the director of blueprint in consultation with the blueprint payment implementation. I'm wondering why you added that.
As an alternative and flexibility. I mean, why? Yes.
Okay, I just didn't know if there was,
questions for.
was there discussion in Senate over?
Not really. I think mostly Dr. Solian can help with that.
The other question I have is
And I will tell you that if I didn't know I was gonna be here today, I might have come up with better answers for you.
I'm wondering about the thought our committees did great work last year around reference-based pricing and, having the Green Mountain Care Board essentially rate setting authority. And I'm really curious in here, it appears as though like the methodology and the rates and the coming up with sustainable funding and calculating what that funding looks like is being given to essentially the blueprint via AHS. And one of the things I'm thinking, the blueprint has not raised their rates in close to 20 years. So why would we give Blueprint and AHS, who has fiscal pressures with Medicaid, why would we task them with doing this?
So stepping backwards, I think looking at Medicaid, for me, Medicaid is really an exceptional payer, albeit at an extremely low rate. But they have really good policies built within the Medicaid program. So beginning with that, and then also with a blueprint, which is unique, they have the expertise in those areas and can begin to look at how to align other payers. So that's kind of where that thinking is. And giving, do you pick it all up and carry it over to the Green Mountain Care Board? That's a question. Or do you allow for the initial fit up and development of this model to happen where it's been happening? Forgetting for a minute that it is extremely low reimbursement and that it hasn't changed in a long time, but we can also influence that. And I do agree with you, it's low and it should be changed.
Then possibly, could we entertain, and I do that AHS has the expertise to develop the methodology and the blueprint has the experience and relationships built within the primary care community to be able to implement. But would you consider taking the actual dollar amounts and giving that to the Green Mountain Care Board, who is a rate setter?
I think once you
Give the money to the
once you
board
get there,
and
yeah,
the process to AHS?
once you get there, we could do that. But remember, we also have federal pressures and federal rules from Medicaid and to the extent Medicare is involved. So it's not for me, it's not as simple as saying the board will do it. But could do that, definitely could do that. I think the advisory committee that we have set up for primary care is going to be extremely useful and informative about how to make those changes. Having a collaboration between the board and AHS initially is a really good idea. I know they have tried to collaborate in the past and might be able to do that in this case. But I think, as I said before, and I do know that the board has a tremendous capacity to do analytic work on all of this. So that's why, that's why a collaborative process is probably the better way to go.
Yeah, I just worry about AHS essentially setting rates for commercial insurance.
I have no, there's no thought about that. I think the thought is, how much should we be paying our primary care providers to ensure that they are sustainable? Once we know that bottom line, and that is part of maybe what the board data can tell us, or the Department of Health data can tell us, or Blueprint data can tell us, any group working together to be able to do that. I know, I would welcome your thought on that. But I think moving it to one place and moving it from one place to the other at this point, trying to shift all of that, is not too much. It's overwhelming. Would become a chaotic process. But if we can do it in a stepwise process, my opinion, you guys can do whatever you.
I haven't asked you this question previously, so
I know.
this could be a fun answer. Is there, I know that we sent you bills that we did not have time to fully bake completely, and love working with you in that way. Is there anything that you didn't get to in this bill that you wanted to put that maybe you'd like us to consider?
Sure. How much to pay primary care providers? No, I think you're asking all the right questions. How can this move forward? And who does the analytic work? You're right. So if we could get to a payment over and above our fee for service, like of $17, we did a little calculation. ACO spent $2.70 over. Blueprint plus the ACO was $7.90 over. ACO, Blueprint, and CPR is $12.90. If we can get to $17, now it might be sufficient to really reward and incentivize our practitioners. But so we don't have that right now.
My last question, I swear it's my last question. I know oftentimes because the budget moves back and forth that bills will come through and the money has been, was there any allocation at all, appropriation in here for anyone to do any of this work or in the original?
Well, I'm trying to remember. What did we put in for that? Was there anything there? No. Was there a fiscal note on this bill? It was not. It did not go.
Okay.
It didn't go to finance. It didn't go to approach. So, however, nice to have some funding to do something.
I believe you sit on appropriations.
I do.
You can make that happen.
Well, no, and thank you for putting in provider stabilization dollars. I mean, on the health side, and there needs to be more of that.
If we had a stable system, we wouldn't need stable.
Yeah.
Daisy, did you have a question?
Yeah, I wonder, I'm contemplating how sometimes payment reform doesn't always align with service delivery reform. And so I'm looking at section 7 where some of that seems to be spoken to, and I wonder if you can just share some of your intention behind that. This is the section that talks about Voss Medical Society by state will report to us on the appropriate transition of patients from hospital care delivered in a community setting.
Yeah, so that relates to someone who's in the acute care facility and they come out of the immediately needing acute care in the hospital. And sometimes specialists or the hospital is delivering the care that perhaps a primary care provider can deliver in the community. So how to take that more expensive care and put it into a place that is less expensive. That's what that section is about. So if you're, you have surgery, you have knee surgery, and then you're getting some kind of PT or therapy in hospital, then how could we have that happen outside with a primary care doc or a primary care provider rather than continuing care in a hospital inpatient setting? A knee's probably not a good example because most people just get up and walk out. Could be it.
Did the committee talk much about that, about how this more specifically aligns with service delivery reform? And I know we've got several other places that that's happening, but knowing that alignment is a theme in your committee, I'm really curious. Because that's always my concern.
Not for this one specifically, but it would align with the other work that we're doing on services and our state action plan in a way, and having primary care in different parts of the state. I think having VMS and VAS, the hospitals and the primary care docs, FQHCs and others working together to think about, well, what are the services where we see specialty care is not really needed? And we couldn't answer that in our committee. That's something that specialists need to do. The practitioners need to be talking about.
Enable them to do that.
Yeah.
Thank you. Thanks for coming up.
Yeah, we probably
Having
not
you
real
up here.
helpful at this point because you've already been through it and have some ideas, but honestly, thanks for taking the bill up. I really appreciate it.
We're spending some quality time with it, so we may have taken it up, but we are far from done with it.
Okay.
Haven't changed a word yet.
I know you will. Keep an eye on you. But no, and the other thing is I do appreciate your questions about who does what, who's in charge, and how are the rates decisions made. But first you have to look at what are the codes that are involved. And then how can we bring together our payers to work together? That's DFR. I mean, DFR could be involved here, right? So trying to sort out what is it that practitioners need to be paid for the services they're giving? And then how can all of those services be put together in a uniform, aligned way for all payers? I went directly to Medicaid because I think they do a good job with that, but you may have another organization that does a better job with it. There you go.
Thank you.
Thank you. Good luck.
Oh, thanks. All right, so we're done for the day. We are back here tomorrow morning at 9 a.m. 197.